right, wonderful, thank you. So basically, the club is for students who are interested in learning more about perio as a specialty. And ideally, we would host lunch and learns. We would do a pig jaw lab and stuff like that. And then we'll also help students through the application process. We'll still do that, but obviously this year it's going to be virtual. That's me, DJMO, class of 2021. Anyone has any questions about anything, I'd be more than happy to help them. Short, very silly thing about me, I'm kind of obsessed with science fiction, and I tend to do that like whenever I can, essentially. VP, Miss Kristen Ritchie. I learned today, actually, that she's a certified lionfish hunter, which is quite fascinating. Please ask her about it. She sent me photos. It's pretty cool. That is Jenny, a classmate. She's great. She has amazing hand skills, so go bother her for everything operative. So today, we'll be doing a pre-op and post-op where the residents will kind of discuss their cases with us, all the surgeries that they perform, just to get us all excited for the specialty. Next year, we will definitely hold a meeting so we can walk you guys through the process of applying to perio. We'll share with you best practices, how to formulate your CV, and also tips on how to do very well on your interviews. And then as of now, maybe is the pig lab. It's a very cool experience. Basically, they're bringing pig jaws into the lab, and you are able to do, to simulate various perio surgeries on them, flap and osseous, distal wedges, step back incisions and stuff like that. It was definitely a cool experience for me, and it was that experience that really kind of got me really interested in the specialty. No word on that exercise yet. I'll be talking to people this year and early next year to see if we can host that, given the pandemic situation. And yeah, that's pretty much it. I am very approachable, so if everyone has any questions or anything like that, please, stop me, send me an email. I'll be more than happy to help. Okay, that's it. I'm going to stop sharing now, and then I think it's Dr. Reddy that has the PowerPoint or something, and then I'll have her take over.
Hey, Michael, do you think you could help me with sharing the screen? It's beyond my capabilities.
All right.
So we all added some some photos to a PowerPoint, and so we'll kind of individually go through a couple of cases, looking at traditional periodontal surgeries, and then also more exciting ones like sinus lifts, ridge augmentations, and SFOT. So Michael will share that PowerPoint, and then when the slides that you put up come up, you can go through your case.
Can you make me a co-host so I can share?
Yep, done.
So we're going to start with some surgical cases, and I have the first one. Mute. There we go. Sorry, I was muted. Okay, so we have a 12-year-old male. He comes in with this really fibrous papilla. And at first I was thinking altered passive eruption, but after measuring everything, it just was a fatty papilla. And we ended up doing a gingivectomy for the patient. We brought it all the way to the adjacent laterals, and this was how he healed. I was very surprised, especially because his oral hygiene wasn't great, but you can do anything to a little kid and they will heal amazingly. Okay, I think Danny has the next one.
You'll have to click ahead for us. This is a flapping osseous case on the upper right quadrant. Did scaling and root planing, and the patient had some deep residual probing depths still. As you can see, he's got a pretty significant buccal buttressing bone here. And so it created or presented a little bit of a difficulty when reflecting the flaps. So as most of you know, the flapping osseous surgery is also called like a pocket reduction surgery. So it's a way that we treat patients with periodontal disease and bone loss with the goal of kind of eliminating the pockets and the bony defects that are there and facilitating better oral hygiene. So if Mike wants to click ahead, this is just that buttressing bone on the buccal. Here's the palatal, unremarkable. And we did buccal sulcular incisions and started to reflect a full thickness mucoperiosteal flap. And you can start to see the buccal bone there and buttressing bone as we went. So we had to do some osseous resection in order to continue to reflect the flap as we move along. A little bit more. And you can see it was almost 10 millimeters in height, so it's pretty significant. The patient was pretty pleased with how it felt afterwards. He said he felt like he had, you know, something up there when the other side wasn't done. So he said that if nothing else, he liked the way it felt better. If you can keep going. So that's the majority of that big chunk removed, and then one more. So this is just reflection, and you can see negative architecture there. We do some osseous resection, osteoplasty, and ostectomy. This is the palatal, and then after degranulation and osseous resection, you can see positive architecture. Thank you for pointing that out, Michael. Same on the palatal. And then we use a continuous or double continuous sling suture to reapproximate the tissue more apically, again, so the patient can keep things clean. And on the buccal or the palatal. And then Copac dressing, just because he had so much excess tissue from the buccal, put a Copac there to kind of help maintain the tissue in the position that we were hoping, a little more apical. And then I think there's a 3-week post-op. So you can see the tissues have healed well. And I think there's a better shot. Next one, Mike. So you can see where that excess tissues was. It's the tissue is kind of contracted and healed pretty well. And then down the corridor. So this is kind of like the bread and butter of periodontics, and where we kind of learn a lot of our surgical skills. It's a tough surgery, physically or demanding, which is a lot of work for us and for the patient, but it's a good surgery for us to hone in our surgical skills for sure.
All right, the next one is on GTR. So GTR attempts to regenerate bone, cementum, and PDL. And you can go to the next photo. So it's great for class 2 furcations on mandibular molars. So here we have 19, a view from the buccal. Go to the next one. And then from the lingual. And then looking at the next photo, looking at incisions, it was a sulcular incision to the alveolar crest, extending from 19 to 21 with a mid-crestal incision over the edentulous area. And then I did a distal linear incision behind 19 just to get better access. It was a full thickness flap, and you can see calculus on the root surface and into the furcation. So even after scaling and root planing, it's, our studies show that it's pretty much impossible to remove all of the calculus in deep pockets. So that's one indication, to do surgery. And then in this situation, once we cleaned out the granulation tissue and the calculus and the furcation, there is also a great site to graft. So once everything was cleaned and root planed using Cavitron and hand instruments, we applied EDTA to the surface and then placed bone and membrane, which is in the next photo. So this is DFDBA, so I'm sure you learned from Dr. Sabatini's class the different properties of bone and how this is more inductive. So it's a better bone to use for like this type of regenerative procedure instead of FDBA. And then placed a guide or a membrane. It's a synthetic membrane that is supposed to hold its barrier function for about 6 weeks. So the principle of GTR is, excluding epithelial cells and giving more time for the bone cells to kind of repopulate that area and turn over the bone into its own natural bone. And then the next photo is of it sutured. These are glycolon sutures. They're slow resorbing, and they maintain their tensile strength for a lot longer than, say, chromic gut.
All right, so we also do some pre-prosthetic surgery, so ridge augmentation, sinus augmentation, things like that to get the patient ready for implants if they don't have enough bone height or width. So go ahead. So this is a patient I did an anterior ridge augmentation on that she lost those teeth, and she had pretty good width, but not a lot of height of the tissue. So in the next photo, you can see that width it looks like it's pretty good. You always need a CT to be able to tell what's soft tissue and what's bone in that thickness. So in the next slide, you can see her incisions that we did. And usually when you're doing these types of flaps, you need to go a couple teeth away. They're usually pretty big surgical sites so that you can advance your flap over and get good closure. And then in the next slide, you can see those teeth taken out and those extraction sockets that are still there, and they haven't really filled in with bone. They're more filled with granulation tissue, and you can see that height of the bone where we want to place the implants is a little higher than the adjacent teeth. And then, so after we have it all reflected and debrided and everything cleaned off, we do cortical perforations, which is where you go in with a burr and make a bunch of holes in the bone essentially, and those are bleeding points to allow good angiogenesis and blood supply into your graft. I think you can see in the next photo as well. You can see those extraction sockets cleaned out also. And then go ahead. In the next one, you can see that all that graft material that we placed. So in this graft, we did FDBA, and then usually also mix that with bioos. So human donor bone, and then also bovine bone. And then in the next photo, you can see we added a little bit of width too, because you always want to overgraft a little bit because you're going to lose some of it, but not so much that you are asking too much of the body to be able to fill in and then also close over as well. And then we place our membrane over it, just like Nithya was talking about. You want to exclude certain cell populations, so you don't want the tissue growing in and replacing your graft material. You want to keep it isolated for as long as possible to form bone. And then we have it all sutured up, and we want to get it really good, nice and close. So a bunch of different suturing techniques and suture types. Those white ones, there's PTFE, so non-resorbable. We need them to stay a little bit longer. But like chromic and glycolon, we're not quite as worried about keeping closed, and it's nice to not have to take out sutures as well. I think you have it from the occlusal as the last photo for that case. And then we can go on to the next one. So another type of surgery that we do is SFOT, or surgically facilitated orthodontic therapy. So it has a bunch of names. People also call it Wilcodonics and PAOO, which is, they're all a similar surgery. So you can see in the CT in the next slide. The patient's just got a ton of crowding. And for this patient, and a lot of these patients, they have really thin buccal plate. His is not as thin as some other patients we've seen. So the primary indication for this surgery is a lot of times you have bigger teeth and you have a lot of crowding and not a ton of bone. So if the orthodontist is going to move the teeth into the correct position, they would be out of bone. So you're kind of giving the patient some more bone, and then a lot of times they get a more soft tissue out of this. You'll see they have really thin phenotypes if you run your finger over the roots. They're really, you can kind of feel the roots and they're bumpy. And then one of the added benefits of this procedure as well is that in the process of doing the corticotomy, so these vertical incisions basically in the bone, and then adding the bone graft, you get what's called the wrap effect, which is basically through all this irritation that you create in the area from doing the corticotomies and the bone grafting, you get more rapid movement of the teeth. So the patient can move through ortho, like trays, if they're doing Invisalign, or just metal braces, they can move through that a lot faster, which is great because then you're not having a lot of root resorption, and they can finish the case quicker. So it's kind of a good selling point for the procedure as well. So this patient was actually a perio patient as well. So this is kind of like a combined flap surgery as well as SFOT. So you can see in the next slide, I did the upper, and so we flapped the whole upper and debrided everything really well. And then in the next slide, you can see the corticotomies that I did. So those big vertical cuts in the bone, and then also those little tiny, just the corticotomy I did in the previous, or cortical perforations I did in the previous case, inducing those little bleeding points. So from doing this, you get that kind of irritation and inflammation of the bone that allows that rapid acceleration, and it gives you good blood supply for your graft as well. So you can see in the next slide that we grafted that area as well. And then in the following slide that we placed a membrane over it, just for the same reason. We wanted to exclude that soft tissue from the bone for a little bit of a time. And then in the final slide, you can see it sutured and replaced. And that patient's doing pretty well, just moving through ortho. So we got that added benefit of getting that thicker bone to move the teeth through, and also just getting through a little bit quicker, which a lot of adult patients would like to do.
All right, so now here's one of my FGGs. Can you go to the next slide, Michael? Okay, so you can see here, this patient had just gotten out of ortho. And when you see patients who have gotten out of ortho, you see a few things here. Number one, you can see the roots of the teeth are very prominent, and you can almost see them through the tissue. And anytime you take a patient through orthodontics, it stretches the tissue and stretches the collagen fibers and makes them really prone to recession. You can see on both the canines, we have minimal, if any, keratinized tissue and no attached tissue. Then also you can see the frenum pull, which doesn't look like it's a problem now, but patients it looks like they have a little bit of passive eruption. And the patient's old enough now where you can make a diagnosis of altered passive eruption, but patients can continue to have passive eruption throughout their teens. So instead of doing, because we have all of this thin tissue, we have the frenum, we decided to do the free gingival graft all the way from canine to canine, and you can't stop on the prominence of the canine, because then that part of the graft will necrose. So we got to go all the way basically from premolar to premolar. So you go to the next slide. So when we do free gingival grafts, you do a super periosteal dissection. So you can see that the periosteum is still on the bone. And actually right there, right where he's pointing is where the frenum pull was. So there was a muscle attachment to the bone. So it's very difficult to, so as I'm pulling out the lip and making my dissection, it actually pulled the periosteum off of the bone. But the rest of it is all periosteum. Okay, next slide. So this is the picture of the palate before the harvest, and then that is one side of the harvest. So I actually took two of those. This was like a 40 or 50 millimeter free gingival graft. And then this is after harvest, and this is platelet-rich fibrin that we suture to the palate. PRF it's a blood concentrate. So that's when you see us taking blood, and we spin the blood down and take the platelets and white blood cells that are, in the white layer, and then we can compress that into a plug or a membrane like we did here, and it helps with soft tissue healing. Okay, and then anytime we do these grafts, you want to take a larger graft than what you need, because we get some shrinkage after. So I mean, it looks like this graft is massive, but actually over time it is going to get smaller. And then we just want to make sure that it's nice and secure and doesn't move when we move the lip. So we just strap it down. And then this is a comparison of preoperatively and postoperatively. So you can see you can see how it was such thin tissue and prone to recession before. And now this free gingival graft is going to last this patient the rest of his life. He is never going to, hear from those canines or incisors ever again. And he's a young kid, probably won't even remember the procedure. So, okay, next. So next is a lateral window with so it's a sinus augmentation, and we actually did a ridge augmentation at the same time. So the plan was to do implants in sites 12 and 14 and do an implant bridge. So you can see down at the bottom, that's the ridge for the site number 12. We need to augment the buccal of that ridge and then also do a lateral window for site number 14. All right, so this is preoperatively. And this is after flap reflection. You can kind of see the hue of the maxillary sinus there, and then you can see the defect on the in site number 12 from the occlusal. Okay, next. All right, this is the window and after reflection of the membrane. So when the patient breathes in, you can actually see the membrane go up inside. So we know there's no perforations. Okay, the next slide is just after we've packed the sinus with our particulate bone. And then the next slide is covering. We put a membrane, a resorbable membrane that comes from human placenta actually over the window there, so we don't get any ingrowth of soft tissue into our maxillary sinus, and then made cortical perforations in the site of the augmentation in preparation for our bone. And you can see it coronally actually made an osteotomy and then expanded the ridge with some burrs that we can actually expand the ridge. Okay, and then next slide. And this is after adding the bone for the augmentation in site number 12. And then the next slide is, this is another collagen membrane, and then covered with in the middle, you see the PRF over our incision line, and then primary tension-free closure with the we use the glycolon sutures to strap the membrane down, and then the PTFE sutures to secure our closure, because there's going to be a lot of tension and swelling post-operatively with this procedure. So then the last case is another ridge aug. This is just a different technique. So the patient has a Siebert-1 ridge deficiency, so they're deficient only on the buccal. Patient is planned for implants 18 and 19. They have a prominent external oblique ridge. So in this case, we're going to harvest some autogenous bone from the external oblique ridge. Here's it was a preoperative intraoral photo. And then this is after flap reflection. You can see the external oblique ridge. Doesn't it look just juicy? Okay, then we we harvest the block there. Okay, and this is the block, and we split it in half and use what the goal of this procedure is, just to use the block as a new cortical plate, because previously when we would do block grafts have cortical to cortical bone, and there was a problem of separation during implant placement. And so what we do here is we pack autogenous particulate scrapings. So you go to the next slide. So this is secured to the buccal, and then we're just going to pack autogenous scrapings in the middle there where the implants are going to go. Okay. And then primary closure. That's it.
Awesome. Thank you so much, guys. That was wonderful. And there is more to perio than scaling and root planing. So I hope that's a good primer, a good introduction to the specialty. Does anyone have questions for the residents? I'm sure there are probably a lot of questions. I'm going to go first. Is there any limitation to the height of a ridge that you can get with a ridge augmentation? Thanks.
I'll take that. Yes, there is. You're limited by the adjacent peaks of bone. And what I mean is, if you have a vertical defect that's bounded by a tooth with no bone adjacent to it, so it doesn't have any bone on it, you're not going to be able to graft vertically up against that tooth. So however high your peaks of bone mesially and distally are, that's going to be how much you can graft to. I mean, we have in our literature on vertical ridge augmentation, predictably they're doing 12 millimeters of vertical augmentation. So, it can definitely be done, and it matters how wide it is. It matters what location it is, but generally, as long as you've got good peaks of bone and someone who is healthy and has good healing potential, and you abide by our, the principles of guided bone regeneration, then yeah, we're going to get bone.
Thank you. If anyone has a question, unmute and ask away.
I'm just kind of curious, when you first start, like, how do you learn these techniques? Because they're so different from what we learn in dental school, like how to do in dental school and our whole skill set.
I suppose I can answer that question because I'm a first year, so it would be more relevant to me at this time. The easiest way to answer that is obviously you're not learning all these surgical techniques in depth when you're a dental student, but as a dental student that knew from like at least third year going forward that I would want to be in some surgical profession, I really pushed and tried to acquire patients and talked to dental students that were either the same year as me or the year above me and asked them if I could get more surgical experience just with something as simple as maybe getting a socket preservation at some point in dental school. And watching is something that is obviously very boring at times. Like you're seeing somebody do something, you don't know exactly what's going on. But when we start being new residents, we're shadowing to such a more intense level than when you're a dental student, because you know that that's the next thing you're going to be doing. So in so many words, I think that we learn most of our surgical skills from the people directly above us and 2 years above us, because I'm seeing them do it. And then potentially the next week I'm doing the same thing. So obviously there's a learning curve. It's not perfect at first, but we have more experienced residents sit with us one-on-one and make sure our surgical technique is how it should be when we're doing our first procedures.
We're also not starting off by doing like a giant ridge augmentation. You're going to start a little bit smaller. And like your first and second year, you spend a lot of time doing traditional periodontal surgery, like the 3 surgeries that Danny, Michael, and I showed. So, you know, we can kind of improve our surgical skills there because there's maybe a little bit more room for error than say when you're doing a sinus lift, you don't want to perforate the membrane, that sort of thing. So you do, at least at VCU, you start small and you work your way up.
And I would also say there's a tremendous amount of reading as well. I mean, for these techniques, you're going to be looking them up and like reading papers, and you come in with an idea of how you want to do it. And sometimes that's what you do with the attending. Sometimes they change it. But these are all techniques that you've read about and discussed with faculty. And like we said, discuss with your co-residents first. So no one ever sits down and goes, I'm going to do a ridge augmentation today, and you don't know how to do your incisions and things like that. You're always very prepared. You know, if you go to your co-residents and say like, I'm going to do a ridge augmentation tomorrow, what do I read? Like I used to do that as like a first, not as a first year, it was like a second year. It was my first one tomorrow. And there's always like, okay, here's a stack of things that you'll never be able to get through the night before, but some things will be really helpful.
Yeah, Nick didn't just decide to section a piece of that mandible without approval of the attending faculty first.
I
guess I have a quick question regarding the sinus lift. You mentioned that there was no perforation to the membrane, but if you did perforate through it, do you just suture it? What do you do in that case?
So there are people who will suture the sterninary membrane, but it's very difficult, and it takes a very fibrous membrane to be able to do that. So most of the time, no, we're not going to suture the membrane. Most of the time, we'll do we'll either, if it's small enough, we can cover it over with one of our resorbable membranes. Or if it's really small, actually sometimes the Schneiderian membrane will fold on itself, and it's not a problem. If it's really large, then you get into other techniques. Or, you know, if it's really, really bad, you know, sometimes people will just bail on the procedure and come back another day, and just try to get closure and make sure that when you come back next time, you can do it a little bit more predictably. So yeah, I mean, it's not a I fortunately haven't had one yet, but I need to have one. I can't, you know, I gotta get one of those, so I have Dr. Waldrop backing me up when it happens. You know?
Well, I can tell you that I've had one, and Dr. Waldrop backing me up. I now have 3 to my name, so
good. Yeah,
you never know.
Hey, look, that's you gotta have those to learn. So,
yeah.
Gotta get them.
Yeah, no one likes to have, I mean, things happen in surgery, and it's sound like you don't want to be like, oh, that happened to me as a resident, but it's actually a really good thing because part of being a specialist is learning how to deal with complications. So the more stuff that happens when you're a resident, when you have support and people to help you work through it, the better it is actually.
Yeah. When you're a resident, that's when you want to, you want to see everything. I mean, you want to see a lot of things, and because you only have access to these faculty for so long. These people are the experts in the field. I mean, all of the faculty we have are phenomenal at what they do, and that's why they're allowed to come here and teach. And they all have different perspectives, and so take advantage of the faculty that you have whenever when you guys do start your residency.
And kind of relevant to that is one small piece of advice that I wish I had when I was a dental student, because I have some of you asking me in clinic and people from UNC that are fourth years now that I was close with. They want to know, what can I do now to like be a better surgeon or be a better periodontist if I know I want to do that? And it's not, I wouldn't necessarily go back in time and be like, hey, Will, you have to read more literature right now and learn these facts. I would just really hone in on anatomy. It's such a tangible thing that you guys can completely understand because you've had a course. And I wish that I was looking at anatomy with a closer set of eyes when I was a third and fourth year dental student. And I don't feel like I have huge gaps in my knowledge or anything, but you learn so much great anatomy when you're a first year dental student. And what that's most relevant for is actually when you're doing surgery, which isn't like till the very end of dental school. So whenever you have an opportunity, just like pay attention to anatomy. Don't be afraid to look up some diagrams in passing if you're going to do like an exostosis removal or tori removal as a dental student. Any opportunity you get to brush up on anatomy and vital structures, I would take it.
Great, thanks. Any other questions? About 15 minutes left, but any other questions? Gives people more chances. Okay, in the absence of any more questions, we'd just like to thank our residents so much for taking the time to come talk to us. This was awesome. I know it's not the best situation. They all get candy by default, obviously. Yeah, you guys should expect some goodies pretty soon. To the students, please don't forget to put your name in your email addresses in the chat, so we can capture that and try to give you guys some gifts as well.
Yes, if you could just stay on for a second. A few more people joined just a few minutes ago, so I'm going to capture everybody. The residents don't have to stay, but the students just for like a few more seconds.
Right.
Hey, those of you that are interested in perio, come through the clinic and spend time with us and introduce yourself so we know who you are and what you look like. And, we can try to introduce you to Dr. Waldrop and the other, faculty and people. Half of the battle is people knowing who you are and kind of getting to know the scene. So come through and introduce yourself, and we can hopefully hook you up with some cool surgeries to watch and help you in any way possible.
Yeah, that's what I did. I spent like a lot of my time third year in grad perio. I got like 50 points from Dr. Hall.
Nice. Yeah, I met Dr. Ha and Dr. Hall. I don't know if it's maybe their first day or first week at VCU, and it was very nice meeting them, and they're always very helpful. So please, if you have questions, watch cool stuff, they are more than there to help you guys. So yeah, the residents are, again, thank you so much. You guys are free to go do whatever it is you do in the evening. I'm guessing studying. So yeah, again, thanks guys. I appreciate it. For the students, just a couple of minutes. Thank you.
Thanks, Deji.
Thanks, Dr. Reddy.
I have everybody participating. Everybody hasn't sent in their emails yet, but hopefully we can find them.
Okay.
Okay, well, I can't leave because the meeting will end if I leave. So I'll be here until everyone leaves.
Oh, yeah, that's right. Okay.
Now let me pause